In terms of what needs to change, I'm not sure if I should say everything. And in terms of who will drive the change, maybe I should say everyone. Unfortunately, when it comes to the GRT communities, the data are not there. So we have what has been identified as invisibility. We shouldn't see invisibility as a coincidence. We should see it as a consequence of a system that we have designed, that we have not built around everyone.
Welcome to Voices of Resilience with me, Mary Mosoeunyane, the show where we amplify Black and minority voices in UK healthcare and education. Good morning and welcome to Voices of Resilience. We have been talking about inequalities across board in terms of how inequalities affect the minoritized in our society. We often use the word global majority, meaning people of Black, Asian, and other ethnic minorities. However, one of the things that seem to be left in the conversation most times is the Gypsy, Roma, and traveler communities who face some of the worst health outcomes in any group that are minoritized in the UK. And their experiences are rarely part of the national conversation. So once again, my name is Mary Mosoeunyane. Welcome to Voices of Resilience, the show that amplifies and advocates for the needs of minoritized in the UK. Today we have Professor Adetoro, and I'm going to say your names in full. So Professor Adeyemi Adegoke for our conversation today. And she's going to be talking to us a lot about some of her experiences within education, within the community such as this, globally as well, she has actually worked. So, Professor Adetoro, welcome to Voices of Resilience, and thank you so much for joining us. Before we dwell into some of the research that you have done surrounding the travelers, the Roma, and other minorities, of course, can you tell us a little bit about yourself, about your background?
Thank you. Thank you so much, Mary. And it's lovely to be here. Thank you for inviting me. So my name is Adetoro Adeyemi Adegoke. And I know you talked about the Gypsy, the Roma, and traveler communities. But I say the Gypsy, the Roma, the travelers, the Showmen and the Boater communities. And I think one thing we should also say is that from the communities, from working with the communities, there are different communities with different needs and challenges, and don't necessarily want to identify as one community. So a lot of people say GRT. I tend to say GTRSB, so Gypsy, Roma, Showmen, Traveler, and Boater communities.
What do you actually mean by showmen and boaters?
So these are people from the traveler communities also, but they are into carnivals. You know, we have showmen that travels, from city to city, and they run shows. They are into the carnivals. But then we have boaters, people that live inside boat. They don't really have like a fixed accommodation, so they live on seas. So they are the boaters. So they live in So let me start by talking about my background. So I would say that because of where I started in terms of looking at the implementation of maternal and reproductive health programs in Africa. So that actually opened my eyes, to a lot of disparities, may not necessarily be linked to race, but in terms of people's locations, in terms of socioeconomic status. I think that's where my career, I would say, in health inequality started. I then over time realized that it's not about maybe Nigeria, it's not about either the UK, it's maybe any of those places. But when we're talking about health disparities, a lot of the root causes are actually strikingly similar. So are we talking about disempowerment? Are we talking about maybe discrimination? Are we talking about systemic barriers? So is irrespective of the location. So my experience of working with the communities, the Gypsy, Roma, Traveler, Showmen and Boaters communities, actually came from the fact that I observed that when it comes to policies, a lot of the policies are silent. A lot of UK policies are silent about this group or these communities. And when it comes to conversations around health equity, unfortunately, those voices are absent as well. So it's much more, I think for me, it's much more about, representing those unheard voices. And I don't really see it as just being professional, my being an advocate, being the voice, for the marginalized communities. I think it's deeply personal as well. So I see it as, focusing on justice, ensuring dignity, and then ensuring that no community or no group is actually forgotten or left behind. So it's about, either in Africa or in Asia or in Europe, it's just about ensuring that all voices are heard and that people are not left behind.
Yeah. You lead the Center of Excellence in Health Inequalities and bring really huge expertise in maternal as well as adolescent health across many countries, just like clearly that you have shared some of your experiences in Nigeria, for instance. So how have your experience informed how these inequalities play out among the, shall I call it GRT for the purpose of our conversation, communities in the UK?
Thank you. So, like you rightly said, so I've worked across 3 main continents, so Africa, Asia, and Europe. And I think, like I mentioned earlier as well too, so when we're looking at what are those inequalities, what are those disparities, so the local context may differ, but unfortunately, the structural drivers are, I don't want to say universal, but that is what we are finding in terms of, those things that are excluding people from being able to access healthcare. And one thing that surprised me was that when I did a study as part of a project in rural Nigeria, and we were looking at what were those maternal health gaps amongst women that live in rural northern Nigeria. And some of the findings that we had then were, unfortunately, I'm seeing them now. They are being echoed amongst the, let me say, the GRT communities. You find women having, or traveler women finding it difficult, to access care because they are delaying care because of the fear of being judged. We have women not accessing care as well because they do not understand the system, or because the system has been designed in such a way, to exclude them. So they find it difficult to navigate that system that has not been designed with them in mind. And of course, all the issues around, culturally inappropriate or insensitive care. So it was really surprising to me to see that what was happening there is actually happening here. And it's because, with that conscious effort to ensure inclusion, of those marginalized communities, I don't think we are doing that appropriately here. So, yeah.
Wow, it's really interesting actually bringing the concept of having worked across the different continents, especially probably because I'm of African origin as well. It's interesting that when you are thinking about disparities, because for instance, Nigeria being mostly Nigerians, mostly Black people living there, and the nature of disparities, while there is some shared elements of it, it's interesting that disparities is disparities regardless as well. But then, when you come to UK, for instance, like for now, as a nation, we are facing a crisis within our maternity services. There's always a story about how, for instance, Black women, for instance, are likely to die or even their child die compared to their white counterparts, followed by Asian groups like that. So in that order. And, it's interesting also that even when we look into research, when we talk about these maternal services, while we are saying, okay, Black women are more likely to die, twice as likely, or even 4 times likely, we never actually mention the travelers or the gypsies. And probably my question to you is, where are they in the services? Are they actually accessing the service? What is going on there?
Yeah. I think if I can add a bit more to what you have just described, you mentioned Black women being, more likely to die. So the data that we have shows that Black women are 4 times more likely to die than their white counterparts. Asian women 3 times more likely to die. Unfortunately, when it comes to the GRT communities, the data are not there. So we have what has been identified as invisibility, in terms of data. And because the data is not there, so you don't even have the data, not to talk about, disaggregating it by the various groups and communities, within the GRT community. So we have, and the other thing also is that if you look at the data set that we have, you have people from these communities, being mislabeled under white other. So unfortunately, you can't break that down because people have identified. And within the community, there's this saying that I think there's this phrase like the passing off as. So passing off as white, passing off as British. So people from the communities self-identify as being white and British because they don't want to identify as coming from these communities because they don't want to be judged and they don't want to be labeled and then be reported. So there's this fear as well, and that is then stopping people either from accessing care or being able to even raise their voice and ask for help. So on one hand, we may have the data, but because the data have been mislabeled, so it's really difficult to disaggregate the data and then identify the disparities. And you know what will then happen? Then it means that funding is not allocated, interventions are not properly designed, to meet the needs of this group. So it's like a systemic chain reaction that, just a lot of things are just happening. Because we have an health system that is, I wouldn't say rigid, but it's not that flexible. So then we miss them because, they have this nomadic lifestyle as well. So the insecurity with housing makes it very, very difficult for maybe except we have outreach. There are examples of midwifery work, in terms of outreach being planned and services being taken, to people from the communities that have actually worked. But in terms of, leaving our health system in that rigid mode of, you have to come, you have to register with a GP, and you have only to be referred by a GP, is causing actually a lot of issues when it comes to access. It's standing as a barrier, for people from the communities, to access care.
What are maybe the specific obstacles that are facing the Gypsy and Roma travelers? I know you mentioned that because obviously they live a nomadic life, they go from place to place, and that could be one of the factors. Beyond that, what else do you think? Maybe just thinking about the community itself culturally.
I think there are issues with poverty, despite the fact that we're talking about the UK and we're talking about maybe regions also where people are being described as affluent. But within those affluent regions too, there are pockets, of communities with disparities. So there are issues with poverty. There are issues also in terms of lack of education because of the nomadic lifestyle as well too. And also, not really understanding and engaging, with the services. I think that is also due to the fact that they have this fear of being judged or being turned over, or being reported. We've seen examples of that in women where maybe children need maybe some specialized care, but then the mother is afraid that, okay, if I should go to the hospital, this baby will be taken off me, I'm going to be judged. So instead, they are home and they are not accessing, the care. So yeah.
You did mention, of course, that there are are quite a multifaceted issues here. You've talked about it can be discrimination, it can be stigma, and of course, it can also be about their unsafe living conditions, which can exacerbate some of these health concerns among the GRT communities. How do these social determinants translate into poorer health outcomes in practice? So now going back to the healthcare professionals themselves.
Yeah. So poor housing, overcrowding will affect physical and mental health. You understand? So it will exacerbate, like you said, the physical and mental health of people from the community. So lack of education will result into some form of poverty or low socioeconomic status, which will affect the type of nutrition and the type of housing also that people have, access to. So a lot of things interconnected. So from those social determinants, housing, education, poverty, or low socioeconomic status. So we have to, and that is why we have to look at multifaceted interventions. So it's not like, once we do this particular silo intervention, that will be it. Because the causes are multidimensional. So it's much more around changing, the system. So there needs to be pragmatic shifts, to ensure that we are not designing interventions for these people, but that we are involving them. They are the ones leading on the interventions that should be designed, and they are also responsible, for the delivery of those interventions, because they know what the issues are. And when we work with them, when we shift that power, to the communities, not only the GRT communities, even the Black and other ethnic minorities, then people are empowered, the communities are empowered. And within the communities, we also have a lot of assets. We have a lot of organizations, that can then work together to ensure that we not only make progress, but those progresses and achievements are then sustained within the communities.
You are listening to Voices of Resilience. We talk a lot about challenges that communities are facing. We have talked about the Gypsy, the Roma travelers, as well as the showmen and the boaters. And of course, these are really big challenges. But in society, yes, there are challenges, but we always live with a hope that something can be done on that. So despite these challenges, where do you see hope, for example, in terms of, we talked about silence in the policies. So in the areas of the policy, the services, or community actions that perhaps can start to shift this kind of narrative.
Thank you so much, Mary. In terms of hope, I see a lot of hope. And I'm a very positive person anyway, and a lot of things are changing actually. So hope, there are a lot of grassroots organizations now, either being established by people from these communities or being led by these communities. I think the importance of that is that people are then raising their voices. Before, when we're talking about the challenges, I was talking about people not being heard, or people finding it difficult, to raise their voice because they don't want to be judged or to be reported. But with all these grassroots organizations that we are now having, so people's voices from the communities are being represented because the community members are setting up these grassroots organizations themselves, or they are leading such organizations. So it's much more around nothing without us. Nothing for us without us. So they are then championing, advocating, for their own needs. The other important thing that is happening also is that we have the integrated care boards. So within our various regions, so they are providing funding and funding towards creating outreaches and culturally sensitive care as well. So that is happening. In terms of academia, there is a lot of focus on supporting people with lived experience, so involving people from these communities in the co-creation and co-production of research. So they are the ones identifying what the issues are, what the problems are, and then they are championing the design and the implementation of those interventions. So things are shifting.
Wow,
things are
that's
shifting.
really wonderful, and definitely a very positive vision for the future. And I appreciate the idea about the co-creation, where the communities themselves are being a part of it. And I think when you participate in something, you're co-creating it, you have some sense of ownership, you have sense of belonging. So you become a bit more proactive, and probably they will engage better to try and improve their own health. Yeah, so thank you so much for sharing that. I just wanted you to mention some of the key examples of best practices or interventions that have improved care for the GRT communities as well as the GRSTB communities, particularly when we talk about mental health and maternity services.
Yeah, absolutely. I think some quick examples are co-created maternity services where women from traveler communities are the ones that have designed and are delivering, the service. And some of those examples are linked to the identification of a peer support system. So that has been shown to work not only within the UK, but also in Ireland, in the Republic of Ireland. So the use of peer support, the use of continuity of care, as well as midwifery outreach work. I think I mentioned that earlier. In terms of mental health, I'm aware of the Safe Space Drop-in Center. So I know you are much more familiar with that. So those have been seen to be working. I think the challenge will be in terms of us upscaling, ensuring that those interventions that have been shown to be effective are being scaled up nationally rather than being left as pilots within different cities and regions. And so the support either from NHSE or from the Department of Health will be to look at those effective interventions and then ensuring that they are scaled up nationally rather than being left within cities and regions.
And also, in what you see, for instance, for the health professionals themselves, there's one thing doing research, and is another how that research relates into practice. So how involved at the moment are the health professionals in this space? Probably mostly the midwives, probably even the emergency services, because, a woman could be in labor and they need emergency services. So while you are doing your research and you are involved in the communities, how involved are the wider healthcare professionals who have to deal with these communities?
I think it's a lot has to do with either supporting healthcare professionals in terms of training. And so not only, we tend to focus on maybe cultural competence, but I will start from cultural humility, understanding other people's culture, and also the health workers themselves being involved as part of the co-creation of the, because there are a lot of like cultural competency trainings that you have here and there, but then who is developing those trainings? So are the community members involved in the development of the trainings on cultural competence? Are the health workers themselves involved? And it's not only in the development of the training, are the communities involved in the implementation of the training, the delivery, being part of the facilitators, of those trainings. So I think there's a project that I'm working on at the moment. And it's called it involves the creation or the co-creation of healthcare pledge. One of the things that we want to do, one of the interventions there, is to develop a culturally competent training for health workers. So the plan is that this is going to be led by the people from those communities in terms of, what exactly is it that they need? What are those barriers? How do they want the health workers, to interact with them, to engage with them when when they come for healthcare services. So it's about pulling or bringing in the health workers themselves as part of that co-creation and co-production, as well as community members. So it's not something that can be done maybe like in offices as researchers, and then you bring something that is already done and say, okay, this is the training package, or this is what needs to be done.
Yeah. Wow, really powerful. Thank you for sharing that. How are this going to be? Who is going to be the person behind creating this kind of change? Who is going to challenge all of those?
Thank you so much. I think I was going to actually comment on what you said earlier in terms of, okay, this is the way we need to be doing research now. This is what we should do, involving the community. I tend to say that is the only way for research to be impactful. Because if you go as the researcher, as the expert, you are not really the expert. The experts are those people that have the lived experience, people that are within the communities. And if they are the ones that have identified the problems and you have worked with them, to identify the solutions and work with them to implement the solutions, like I mentioned earlier, then those gains or those results are much more institutionalized or sustained. So even after your funding has ended as a researcher, the communities, community members, community organizations will continue, to implement those interventions without external funding. So in terms of what needs to change, I'm not sure if I should say everything. And in terms of who will drive the change, maybe I should say everyone. But I will then talk about maybe how we should all get involved in terms of what should change. I talked about as researchers or as programmers as well. We need that shift in orientation, that shift in culture to do things with the communities. So, or we do things for the community. By for, I mean that the communities identify the problems and then the solutions, and then we work with the community, to implement whatever you want to or you have agreed to implement. Not that you are doing something to the community and then you are coming in, having that power. So there needs to be that shift. I think in terms of what needs to change as well, we talked about data and data invisibility. So what needs to change in terms of policy, in terms of when we collect data, we need to ensure that we have people from the GRT. So it's an identified ethnicity, not that they are then being lumped under white other, or they can, So we need to recognize, we need to accurately capture, the ethnicity of people from these communities. The other thing we need to do, what needs to change is, we talked about the training. So that needs to change, and that needs to be co-produced and co-implemented with people from the communities. We talked about trust. I think at the beginning we talked a lot about trust. So a lot of investment we need to go into trust, and like we know, it will take some time to build that trust, because mind you, the mistrust came from a long history of discrimination, of racism. So it's going to take some time. So we need to focus on building, that trust. And like you mentioned earlier, not only for people from these communities, even from Black and other ethnic minorities groups. So, so.
Really powerful. And maybe just mentioning that it's really interesting that so far I have had two of my guests actually kind of saying the same thread about silence and the invisibility element of it. So it's really interesting that, yes, we are now being aware of this. We are having a conversation which probably is being heard by the nation, our listeners, and they will be paying attention to some of these things. And some people may be either they are health professionals, they are community leaders, they are educators, and they may also be listening in and really finding this information useful and probably wanting to do something about it as well. So for those who are listening, who want to support the underrepresented groups like our Gypsy, Roma travelers, the Showmen and the Boaters, what one small step can they take today to become more informed or more inclusive. Maybe we can even talk about allyship, because there may be people outside of the communities who really want to help as well. Yeah.
So let me say that the first step would be for people to get educated, being aware of the lived experience and the history of people from those communities, the GRT communities. And then some of the issues, some of the things causing the barrier were are wrapped around stereotypes. So maybe I should say that when people see those issues coming up, we should challenge it. We should not keep quiet or overlook or ignore or pretend as if we've not seen. And I would say to researchers, I would say to policymakers and healthcare professionals that if you look at the data that you are holding or the policy that you are holding, who is missing from that data? Whose voice is not there in that policy? Whose decision is not being recognized in that policy? And so when you define inclusion, who is missing from that your definition of inclusion? And when you find that answer, then you should make sure that you do something about it.
There's really power in speaking out, and probably here at Voices of Resilience, this whole aim or purpose of this discussion is really to bring these voices to speak up for the communities that we are serving. So, Professor Adetoro, thank you so much for your work and your voice today. Thank you so much. It's really been wonderful. So, where can our listeners learn more about your research or connect with the Center for Health Inequalities?
Thank you so much. So, the Center for Excellence in Health Inequalities is a research center. But we not only do research, we work on advocacy and policy as well. So it's a center within Buckinghamshire New University. So if you go to the Buckinghamshire New University website, we have a webpage for Center for Excellence in Health Inequalities, or CEHI. I wouldn't say very active. I'm active on LinkedIn. So on LinkedIn, we tend to put some blogs out there or some short articles. So you can follow me on LinkedIn. And so
absolutely.
We'll continue with the engagement and the interaction.
Lovely. Please follow Professor Adetoro on LinkedIn. Yeah. And I'm sure now she's going to up her game on LinkedIn. Yeah. And finally, what's one key takeaway would you love for our listeners to remember from our session today?
I think we talked a lot about invisibility. And I want to say that the key takeaway would be that we shouldn't see invisibility as a coincidence, as something that just happened. We should see it as a consequence of a system that we have designed, that we have not built around everyone. With the systems that we have built in such a way that is excluding people from some marginalized communities. So we shouldn't look at invisibility as, it's just happening, but it's a consequence of our action. But we can do something about it. We can change that system by ensuring that we are intentional about including the voices of people that have been excluded. So I want to say that equity, I believe that equity when it comes to health starts when we start ensuring that we are seeing people that we're supposed to see.
Wow, thank you so much. And thank you so much to our listeners, because without you, there would be no point of us sitting here and having a conversation. And of course, the wonderful production team has done so marvelous. Thank you so much, you guys. Without you, I don't think this was going to exist. So really thankful. Thank you so much.
Thank you. Thank you so much.
Thank you so much for watching. If you enjoyed today's episode, please do subscribe, like, and leave a comment. I would love to know your thoughts. Please join me next week when I'm in conversation with Professor Damian Page about inclusion, leadership, and the future of equity in higher education. Until then, take care and keep listening to the Voices of Resilience.